It's my honor to introduce Dr. Carla Davis, who received her Doctor of Medicine from Duke University before going on to the Baylor College of Medicine, where she's really remained since. She completed her pediatric residency and fellowship in allergy immunology there at Texas Children's. And following completion of fellowship, received a faculty appointment with the Baylor College of Medicine, where she really started the Texas Children's Hospital Food Allergy Program. She continues to be the director of that program that has now been recognized as Food Allergy Clinical Center of Excellence, as well as a member of the NIH-funded Consortium of Eosinophilic Gastrointestinal Diseases. This has become the section head of allergy, immunology, and retrovirology in the Department of Pediatrics back in 2018, and where she now holds the Janie and Sandra Queen Endowed Chair in Immunology and HIV/AIDS. She's contributed to over 80 peer-reviewed manuscripts, reviews, and book chapters, and has received a number of awards and lectureships for her clinical research and educational accomplishments focused on pediatric food allergy and eosinophilic GI disorders. Unfortunately, Dr. Davis wasn't able to be with us live today, but she has a recorded presentation entitled The Promise and Limits of Allergen Immunotherapy.
Good morning. My name is Carla Davis, and I'm pleased to be with you here to present the promise and limits of allergen immunotherapy. I'm going to take us through a journey, and these are my disclosures. And in relation to this presentation, I have several research grants that I participate in clinical trials and funds those clinical trials. And I'm a consultant for Moonlight Therapeutics, and none of these should influence what I tell you today. I'm going to talk about the history of food allergen immunotherapy, as well as allergen immunotherapy. Talk about the current protocols, oral, sublingual, and epicutaneous food immunotherapy, and the outcomes of the trials in terms of their not only clinical outcomes, but the evaluation of sustain and responsiveness, because this idea of sustained and responsiveness to food ingestion is really what we're looking for to move closer to tolerance. And I'll explain a little bit more about that later. I'm going to talk about some of the limitations of allergen immunotherapy protocols and what's the promise for the future. In 20 minutes, I will try to really do this comprehensive overview. So what is the history of allergen immunotherapy? Well, it's been really over 100 years since, really now 110 years, since the first use of subcutaneous immunotherapy by Leonard Noon for hay fever. And then in 1965, there was a co-discovery of this antibody, immunoglobulin E, by Drs. Ishizaka and Johannesson and Binnock. And there were the subcutaneous clinical trials that went on. And William Franklin was an allergist who was the first to really discover that a higher dose of allergen immunotherapy really seemed to be more effective than lower doses in aero allergens. And then Dr. Scatting in 1986 did the first sublingual immunotherapy double-blind placebo-controlled trial. And so you can see here, really, there was a long time in the early part of the development of allergen immunotherapy before things began to move into other modes of administration. And then to move into the arena of food, Hal Nelson and Donald Lyons were the first to publish in 1997 a rush immunotherapy subcutaneous trial for peanut. And although the side effects were quite severe, it was shown to be effective. So the history of kind of the modern era since 1997 was really, I should say for food specifically, we have this case report from 1908 of the first case of oral immunotherapy for egg anaphylaxis in an adolescent. But more modernly, oral immunotherapy, which is OIT, or sublingual immunotherapy, SLIT or SLIT, to peanut, milk, and egg has been investigated, and SLIT to hazelnut, peach, and kiwi, so fruits and vegetables, have also been investigated. And the lessons learned have been really that oral immunotherapy seems to be more effective than immunotherapy. I'll show you a little bit of that data. And then sublingual immunotherapy, how it seems to be safer, however, than oral immunotherapy. And then in 2012, we learned that biologics can be linked to immunotherapy in order to reduce adverse reactions. And then later, really more recently, since in the last decade, we've expanded to epicutaneous immunotherapy and have noted that that has variable efficacy depending on the patient, but increased effectiveness with longer duration of time. I'll show you some of that data as well. So phase 3 trials have been completed for peanut oral immunotherapy and epicutaneous immunotherapy. And as you know, really in the last year, we've had the FDA approval for peanut oral immunotherapy. So it's really been a 20-year journey, even more than really 100 for us to get to this modern era. So today we'll just briefly talk about some of the protocols and what we've been doing. In order to understand these food immunotherapy protocols, there is some nomenclature that's helpful to understand. There is, this is a schematic that talks about how we move from allergy to tolerance, and so there's always a build-up phase in the beginning, and the dosing is typically either multiple times a day or once daily. And so there's typically an initial dose escalation and then weekly or bi-weekly dose escalations during the build-up phase where the food is taken in the office during the updosing visit and then taken daily at home. And then there's a maintenance phase. Once we reach the top dose, we keep that going. And it's still not completely determined exactly how long this is necessary in order to desensitize a patient. The desensitization is the state where the patient is able to take the food without reaction. Then there's this really what I would consider the holy grail, of food immunotherapy, and that is getting to this state of tolerance. We normally eat food without worrying about the time and the days that we take a break in between eating the food and we don't have reactions. And so this is the state of tolerance. And so if we could get to a point where after we treat for the maintenance phase with daily food, we could stop that food and then measure the dose of food that causes a reaction through a challenge in the office, but right at the point of stopping the maintenance dose and then a period of time afterwards, then this period there is called sustain and responsiveness, because right now we haven't been able to reach the point at which patients could completely keep their level of tolerance to a specific dose of food. It tends to wane over time. So throughout this next few minutes, I'm going to talk about sustained and responsiveness and how immunotherapy protocols have impacted this. So in order, as we move forward, just keep in mind that one peanut kernel is about 250 to 300 milligrams of peanut protein. You can imagine in biology, we have differing sizes of peanuts. So for this talk, we're going to talk about 250 milligrams as the standard peanut. And so peanut oral immunotherapy has really been demonstrated, as I mentioned, to increase the reactivity to the threshold of reactivity in a patient to peanut protein. And so the earliest studies desensitized to doses up to 4,000 milligrams or 4 grams, and recent studies use lower doses, typically 300 as a maximum, in order to allow the patient's protection against accidental exposure. Not that they can go and eat a peanut butter sandwich, but just a protection against this accidental exposure. And the way that we assess the effectiveness of this immunotherapy is through the double-blind placebo-controlled food challenge. This is the gold standard method, and the higher the dose that elicits a reaction, the more protected the patient is and the more effective the immunotherapy is. In immunotherapy, it's just specifically oral. The end of treatment, double-blind placebo-controlled food challenge, the top cumulative doses of peanut protein that are ingested, and this happens within a day, are typically 5 to 10 grams maximum. So this is the landmark study that led to the FDA approval of peanut oral immunotherapy called Peanut Allergy Oral Immunotherapy Study for AR101, which was the product of peanut powder for desensitization in children and adults. And in this particular study and how the FDA approved treatment is designed is that there's an initial escalation day from 0.5 to 6 milligrams, and then an updosing from 3 milligrams all the way up to 300 milligrams. So at the end of about 6 months, patients can eat about 1 peanut. They have ongoing maintenance, and so we know now that that sustained unresponsiveness is really not something that is achieved at this dose. The response to peanut oral immunotherapy with this protocol, you can see here the placebo is in light blue, the product or peanut powder is in dark blue, and then these are the different ages, 4 to 17 years and 18 to 55 years. On the y-axis, there's the participants that have response to the trial regimen, and then there are the doses that were given during the challenges, and how many patients were able to tolerate those doses. And so you can see here that the younger children had a better response than adults to oral immunotherapy, and more of the children that and more of the adults that got the treatment were able to tolerate 300 milligrams as opposed to the higher doses. So there clearly are dose limiting effects. And then at the end of study challenge, the symptoms were assessed, and so these are the doses on the x-axis of the food challenge that was given for the placebo patients and the treated patients. And as you can see here, with the red and the yellow indicating a moderate to severe reactions on each specific dose during the end of study challenge, the symptoms were less severe. And so this is also an important outcome of oral immunotherapy. Now, as I mentioned before, children 4 to 17 years of age did better than the adults. And so the question was, well, how would very young children do with this therapy? And so Brian Vickery and colleagues did a early oral immunotherapy study in 9-month to 3-year-olds with low dose, so 300 milligrams or 1 peanut, versus high dose, or about 10 peanuts daily. And they compared them. And so they looked at 1 month of sustained unresponsiveness after the treatment, and in the intention to treat as well as per protocol populations. You can see here that the low dose was just as effective as the high dose, which was surprising but very instructive. And so the proportion of patients that actually after that sustained unresponsiveness period that were able to put peanut into the diet was actually up around 75%. And so really highly significant from the control. So it definitely performed well in children. And so the FDA approved product is 300 milligrams. And so we are excited to see how that is able to change the lives of patients, because quality of life is improved after this treatment. I did want to mention that there are some real world experience studies that look at protocols that are occurring in private practices, and so the starting is very similar to the Palforzia peanut oral immunotherapy FDA approved product with starting doses of 2 micrograms, a little bit smaller, and then up to 2 milligrams on the first day, and then there's a twice a day dosing escalation, which differs a bit from the FDA-approved product, which is once a day, with a post-observation time of 45 minutes. And the doses to complete the escalation is 21 doses after day 1. The top maintenance or target dose is 12 peanuts, which is 3 grams of protein. So this we consider kind of a high dose, and then passing a 24 peanut challenge. And so 80% reached the target dose, but only 6.5% of these patients reached sustained and responsiveness. This was a retrospective study, so not very rigorous, but still instructive as to what's happening in the practices across the nation for peanut oral immunotherapy. Discontinuation occurs more frequently in older children. So when this peanut oral immunotherapy is started in the younger ages, just there's the percentage of children that don't complete tend to be smaller. So there is thought, especially given the effectiveness of the early oral immunotherapy with low dose, that there is some malleability of the immune system early on that really is positively impacted by peanut oral immunotherapy, and some of the this also is consistent with the learning early about peanut study, which wasn't a treatment study, but still was quite impactful. So peanut sublingual immunotherapy is another administration modality where you can see here it's a very small amount of peanut protein that is placed under the tongue in a liquid form. And so here in this chart is a listing of this comparative study of sublingual immunotherapy for peanut versus oral immunotherapy. And so you can see here for the doses and the weeks on immunotherapy, when you compare sublingual immunotherapy to oral immunotherapy, you can see the doses are in micrograms, much less dose amount compared to oral immunotherapy, and the increase in doses from week to week is approximately 100 to 150 for the sublingual immunotherapy, only 100 in the oral immunotherapy, and it drops to about 50% increase with steps later on, whereas the sublingual immunotherapy just keeps increasing. There are more steps needed, and the maintenance dose is really more around 2 to 4 grams. So big differences, but interestingly, when we look at oral immunotherapy effectiveness, so this is the change in the oral food challenge dose that was tolerated. You can see that when we look at the kind of time for after treatment, the median dose that's tolerated in patients that are on SLIT, which is indicated in the red, whereas oral immunotherapy is in the blue, and there's an open label period that's in the purple, where SLIT and OIT were utilized. But looking at less than 1,000 milligrams that were tolerated versus up to like 10,000 milligrams of oral immunotherapy, you can see oral immunotherapy is more effective than sublingual immunotherapy. But there is some mild effectiveness of sublingual immunotherapy. And I just wanted to highlight that in looking at biomarkers, which are in A, B, C, E, and an F here, and there is a minimal change, statistically significant, but kind of large overlap in the peanut specific IgE, where it's a little bit more potentially at 12 months in the OIT patients. Peanut IgG4, the blocking antibody, is a little bit higher at 12 months for OIT, statistically significantly higher. And then the ratio of peanut IgE to IgG4 is lower in the OIT patients. So from a biomarker standpoint, there is some evidence of immune differences. And then when we looked at the peanut protein tolerated in this comparative study. SLIT really in very much consistent with the last study showed that SLIT's patients did not tolerate as much peanut protein as oral immunotherapy patients. So in looking at tolerance protocols in food, we can see here that this is, they're capsules and then a sachet with the peanut protein. But when we look at the dosing for the peanut patch, it's 0.25 micrograms and it doesn't change. It's a small discus and it's on the skin. And so this very small amount on the skin has been evaluated and has gone to phase 3 trials, which is this PEPIS randomized clinical trial where the patches are placed on the back. The dosing, again, for each patch is 250 micrograms. And the initial updosing is just the number of hours on the back, 6 hours, 12 hours. And then once it escalates to 24 hours, then one patch is placed in each of these different areas for these days, and it's alternated. So each number would indicate the placing of the patch, and then for 6 days, and then the pattern repeats itself. So the phase 3 pivotal study in 356 peanut allergic patients from 4 to 11 years of age was performed, and patients were randomized to a placebo patch or a peanut patch. And then the eliciting dose on a food challenge was assessed at month 0 and month 12. And what was found is that for the percent of patients in the peanut patch group that had an eliciting dose that increased after 12 months of therapy was about 2/3. And then in a placebo, it was about 30%. And so this modality of immunotherapy treatment is still undergoing some more evaluation, and so this for some patients could be something that does help sustain, and responsiveness has not been evaluated. And just to look at this peanut-specific IgE and IgG4 for these treated patients, the specific IgE does what we'd expect, which is to increase initially during treatment and then decrease. And then the peanut-specific IgG4, the median has increased over the treatment course. The skin reactions occur with the peanut patch treatment and tend to, for the during the escalation period of time, can increase, but then after about month 3 to 6, it tends to slack off. Also, the systemic reactions with peanut patch treatment have not been described. So safer than oral immunotherapy, because oral immunotherapy is associated with systemic reactions and anaphylaxis, but the epicutaneous immunotherapy, not as much. So did want to talk about the protocols more recently, follow-up, looking at after week 130 after treatment of the patch. This particular graph shows the cumulative dose that was tolerated in the placebo, low dose, 100 micrograms of the patch, and then this is the 250 microgram dose. And so you can see here that after 130 weeks of treatment, just huge variability in the responses. But you can see that over time, it seems that there are more patients that are moving into the arena of being able to tolerate the cumulative dosing. Now, looking at age and different ages, we can see the age at the start of the active treatment and whether the desensitization was a failure or a success. You can see that more of the blue pluses are in the lower range. So we can see here that this also shows younger ages could be more responsive to this patch therapy. I really like this schematic of the effect of food allergen immunotherapy on responses, because this shows that really what we're looking for is to decrease the reaction severity after food exposure, because this is the intolerance. So these food exposures can cause these reactions, and food allergen immunotherapy, it can be decreased. And what we really would love is sustained responsiveness, where after the treatment, no reactions occur. Hyporesponsiveness would be what we've seen in the oral immunotherapy, that the reactions are lessened. And so this is something that we just need more investigation into. And so at our center, we looked at a long-term 3-year maximum dose food immunotherapy study, where we had an entry food challenge with biomarkers after the screening period, and then an updosing period. And as I mentioned before, 300 milligrams has been the top dose utilized in the past, but we utilize more close to 4,000 milligrams for a maintenance period that was 2 years. And then we did an exit double-blind placebo-controlled food challenge, and then we looked 1 month later for a sustained responsiveness. We utilize also in this challenge a large dose of peanut to 26 grams, 26,000 milligrams, to see what is the maximum dose that these patients that are on almost 4,000 milligrams can tolerate. So what we found was that really within a year, most patients were able to reach at least kind of 3,000 milligram dose level, and then, but when we saw that, when we stopped the treatment, we saw that the dose, even after 3 years of treatment, the dose precipitously dropped after a month. And not all patients underwent, as you can see, this the sustained unresponsiveness period, but it was quite surprising to us. At baseline, our patients tolerated about 73 milligrams, or a third of a peanut, and then after these 3 years, could tolerate on challenge 37 peanuts. But then after 1 month of avoidance, it dropped down precipitously. So we really, this confirmed that even if you treat with a high dose for a long period of time, really there's this precipitous drop in the tolerance level. And then looking at the peanut IgE and peanut IgG4, after this sustained and responsiveness period, we saw that the peanut IgE increased and decreased. And then the 1 month of sustained and responsiveness period didn't really do much to those patients. And but the peanut IgG4, the block antibody, really uniformly decreased in the patients that did the sustained and responsiveness 1 month. So we believe really that peanut IgG4 is really a pretty significant component of maintaining desensitization in patients. So in summary, this is just comparison and limitations of food immunotherapy, looking at oral, sublingual, and epicutaneous, with the route of administration: oral in the mouth, sublingual under the tongue, and epicutaneous on the skin. In the foods evaluated, which we've discussed, the daily doses differ between each of these different protocols. With oral immunotherapy, the FDA approved being 300 milligrams, so just a little bit over 1 peanut, up to 4,000 milligrams. Sublingual immunotherapy is more like 2 to 7 milligrams, so much lower, but less effective. And then epicutaneous immunotherapy is really a quarter of a milligram. So the efficacy, again, large for oral, small to moderate for sublingual, small for epicutaneous, but somewhat variable. And all of these seem to work well in very small children. common side effects. 3 to 4% of oral immunotherapy patients can have systemic side effects, including anaphylaxis, and oral and gastrointestinal symptoms are quite common. And eosinophilic esophagitis can also occur. So more side effects, although there's large efficacy, there are large side effects. And then in sublingual immunotherapy, there's local oropharyngeal side effects, and then rarely a systemic side effect, but much less than oral immunotherapy. And then for epicutaneous immunotherapy, no systemic reactions have been reported, but again, a lot of skin issues. And so none of these can achieves this sustained unresponsiveness. So what is the promise of the future of immunotherapy? Well, OIT with oral immunotherapy with probiotics, herbal formulations, and other adjuvants are being evaluated. Biologics that you just heard from Dr. Sharma, omalizumab and dupilumab as monotherapies or in combination with allergen-specific therapies to improve safety and potentially try to achieve more sustained responsiveness. I think oral immunotherapy for non-peanut items I've listed below, the shrimp and cashew, pistachio, walnut, and a pecan. And we need to understand really how immunotherapy can impact these other food allergens, because they are quite common in patients. And who are the best candidates, the best patients for food allergen immunotherapy? Because of the cost, the frequent side effects, immunotherapy is not going to be for every family. And how can we really identify what's best for and improve the safety for all patients? Well, thank you very much for inviting me to speak. This is our food allergy program, and hopefully you can come and visit us in Houston, Texas. This is Texas Children's Hospital, and I'm sorry that I can't be there to take questions, but very pleased to present today. Thank you.